On behalf of the Delaware Healthy Mother and Infant Consortium and the Delaware Division of Public Health, we welcome each of you to our webinar today. This webinar will focus on our 2018 initiative to promote optimal interpregnancy interval for childbearing women. We are very pleased to introduce our speaker for today's webinar. Heather Baker is our Preconception and Perinatal Project Coordinator. Her position is through the March of Dimes, and her efforts are focused on activities supporting the Perinatal Cooperative, in addition to promoting preconception and interconception efforts here in Delaware. Heather earned 2 bachelor degrees from the University of Delaware. These degrees include a biology degree in 1995 and a Bachelor of Science in Nursing in 1997. Heather has been instrumental in launching this birth spacing campaign, which has been jointly supported by the Delaware Division of Public Health, the Delaware Healthy Mother and Infants Consortium, and the Delaware Perinatal Cooperative in collaboration with Worldway's Social Marketing. We are all very fortunate to hear from her directly about this birth spacing initiative and how it is part of our larger effort of promoting reproductive health and reproductive life planning. Our goals are to promote healthier women so that if and when women choose to become pregnant, we can increase the potential for healthier babies. Heather, thank you again for your efforts to create this presentation.
Thank you, Susan. Today's webinar will be planning for future pregnancies before, during, and after. I have nothing to disclose. Today's objectives are 1, to identify the importance of the reproductive life plan as it relates to family planning, unintended pregnancy, birth spacing, and overall improvement of women's health. 2, to identify the what, why, when, who, and how of Delaware's birth spacing campaign. 3, to identify goals, challenges, solutions of the postpartum visit as it relates to birth spacing. 4, to identify birth spacing resources that are available and how to order them. 5, to identify the rationale for interconception care and potential impact on women's health in future pregnancies. And finally, to identify Delaware's 4 key pillars of health. So first, why is reproductive life planning so important? Well, we know that lack of planning for pregnancy and pregnancy spacing, management of health conditions, environmental risk factors, and negative health behaviors that affect pregnancy outcomes can lead to unintended pregnancies, increased risk for preterm births, increased risk for low birth weight births, increased rates of birth defects, poorer health status for women, increased health disparities, and increased risk of infant mortality. And so if we look at our unintended pregnancy rates nationally as compared to our state of Delaware, what we found in 2016 that Delaware has one of the highest unintended pregnancy rates in the nation at 57% of their pregnancies coming in as unintended as compared to our nation's rates of 45%. We also know that in Delaware, our Medicaid population, as indicated on our PRAMS data, indicated that between the years of 2012 to 2015, that women who carried Medicaid as their payer of insurance, approximately 67% of those women indicated that their pregnancy was unintended, as compared to our non-Medicaid women who indicated approximately 39% of their pregnancies as unintended. If we look at the years 2012 to 2014, our PRAMS data indicates that women less than 20 years of age indicated that their pregnancy was unintended at a rate of 84.7%, as compared to our women of 20 to 24 years of age, approximately 67% indicated that their pregnancy was unintended. 25 to 34 years of age, these women indicated their pregnancy as 42.8%, and then 35 years and older, 42% indicated that their pregnancy was unintended. If we take a look from the years 2012 to 2014 by race and ethnicity, our white non-Hispanic women indicated that approximately 43% of their pregnancies were unintended. Our Black non-Hispanic women indicated approximately 68% of their pregnancies were unintended, and then others, including Hispanics, approximately 55% of their pregnancies were unintended. We know that lack of reproductive life planning can impact our preterm birth rate across the nation and then in our own state of Delaware. So nationally, we know that our preterm birth rate is about 9.8% of our births are preterm births. And if we take a look at our own Delaware data, we're above the national average at 10.1% of our births being indicated as preterm births. We also know that in Delaware, the preterm birth rate among Black women is 36% higher than the rate among all other women. We also know that lack of reproductive life planning can affect our Delaware infant mortality rates and our infant mortality rates across the nation. So we know that from the years 2000 to 2013 that our statewide infant mortality rate was 8.2 deaths per 1,000 live births, as compared to our national data, or the national infant mortality rate was 6.7 deaths per 1,000 live births. So again, Delaware is above the national average. If we look at our own state, we can see that there's some disparities in regards to where we live. So along the I-95 corridor, we see higher infant mortality rates in the Dover and Camden area as well. If we compare our state nationally, compare our state Delaware to the national data from 2001 to 2015, we can see that we're making great strides in reducing our infant mortality rates, but we still have quite a bit of work to do. And in fact, our Black babies are dying at a rate of 2.5 times more than our white babies. So while we continue to make strides, we still have a tremendous amount of work to do in that area. And so that's where the reproductive life plan tool becomes really important for planning for future pregnancies. We know that the importance of the reproductive life plan is to help decrease the unintended pregnancy rate, which contributes to poorer outcomes for moms and babies. And we have been able to determine this based on where we compare nationally. Reproductive life planning is a set of goals based on one's personal beliefs and values. It takes a look at the individual's health now and where they would like to be in the future. It also asks the question of whether or not there is the desire of future pregnancies, and it serves as a basis for action. First, I think it's important to note that the responses to the reproductive life plan should not be considered right or wrong, but rather as an opportunity to start a conversation as to where the individual is, and then to provide relevant health promotion and disease prevention and counseling. So we always want to ask the question to the individual to think about whether or not they want to have children someday or plan on having a baby in the next year. And if they indicate that yes, they do, what does that look like for them? If they indicate that they don't want to have any children, again, what does that look like for them? And in Delaware, we have this saying that if you don't have a plan to prevent pregnancy, you probably should have a plan to get pregnant, with our unintended pregnancy rate near 60%. We also ask the individual to take a look at their own health now. How healthy are you, and is there an opportunity to provide education around this area where the individual might identify a need for improvement? And again, this offers an opportunity for discussion and future conversations. We also want to ask the individual to take a look at and be able to identify whether or not they have a chronic condition. And do they understand that there is the potential for their chronic condition to affect their pregnancy? This opens up the conversation to let them know that not only can a chronic condition affect their pregnancy, but that a pregnancy can affect their chronic condition. We also want to ask the individual to take a look and think about their family history. Is there something in their family history that would affect their health or the health of their baby? And are they prepared for any potential health problems? And then asking the individual to take a look at their emotional wellness. What does emotional wellness mean? I think we spend a lot of time focusing on a woman's physical health, and we don't always spend enough time focusing on their emotional wellness and what that actually means to that individual woman. And I think, asking them, what does that mean to you? Does it mean that you're never going to get upset or angry? Of course not. It means that you're just going to bounce back from those times where you feel sad or angry or confused. asking the woman, what does she do to appreciate herself? Is she able to find balance and purpose in her life? Does she feel a connection to others? And certainly asking the question, does she have a safe place to live? Is she in a healthy relationship? Does she know where to go if she unfortunately is not in one of those healthy situations? And certainly asking her what her level of stress is, since we know that stress can affect the health of a woman and her future babies. And so the overall goal of reproductive life planning is to lead to intended pregnancies, which leads to better health outcomes, which leads to healthier women, men, and babies. Which leads us into our birth spacing campaign. So roughly about a year ago, we began having conversations around the birth spacing campaign. And as a result of looking at some trends that we were seeing while we were reviewing cases in our fetal infant mortality review team, we found that we were seeing some really bad outcomes for moms and babies. And when we started to ask the questions around birth spacing, what we were finding is that there was little to no education being provided around this topic. And we thought that this was a great opportunity to create some educational materials and to provide a statewide initiative around the birth spacing education. And so now I'm going to talk to you about the what, why, how, when, and who of our birth spacing campaign. So the what. So what we really wanted to do was to create a birth spacing campaign to educate, encourage, and entitle women of childbearing age to wait at least 18 months between giving birth and getting pregnant again. And for those of you who are familiar with our Kicks Counts campaign, we wanted to make sure that we were giving the same message throughout the state. And why did we want to do this? Well, we know that a woman's body needs time to heal and recover from the physical and emotional stress of pregnancy. We also know that it's recommended by ACOG, the CDC, the World Health Organization, and our Fetal Infant Mortality Review all support optimal interpregnancy interval. We also know that about 1/3 of pregnancies occur within 18 months of a previous birth. And for each month that IPI, or interpregnancy interval, was shortened below 18 months, preterm birth increased by 1.9%, low birth weight increased by 3.3%, and small for gestational age increased by 1.5%. And while this is national data, it really gave us an opportunity to dig a little deeper into our own Delaware data. And what we were finding is that our Delaware data mirrors our national data. And so if we look across the state of Delaware, we're finding that, again, just as infant mortality rates are different throughout the state of Delaware, we're finding that our interpregnancy intervals less than 18 months are also different across the state of Delaware. And again, kind of highlighting our I-95 corridor, Dover, Camden, Georgetown areas as areas where interpregnancy intervals are less than 18 months. If we take a look, we said that about approximately 1/3 of all pregnancies are within 18 months of each other on a national level. So if we look at our very own Delaware data, we're seeing that approximately 30% of our pregnancies are falling within 18 months of another one. So again, aligning with our national data. And if we take a look at the characteristics of Delaware women with an interpregnancy interval less than 18 months from 2008 to 2015, we're seeing that approximately 74% of our women that are less than 18 years of age are having an interpregnancy interval less than 18 months. Approximately 32% of our women ages 18 to 34 years of age are having an interpregnancy interval less than 18 months. So again, it seems to be in correlation with our national data. If we continue with the why, we know that there are a lot of benefits for mom, baby, and family. Specifically for mom, we know that it gives mom time to recover emotionally and physically from the demands of pregnancy. It allows her body time to restore key nutrients and vitamins that she may have lost during her pregnancy. It allows mom to have time to return to a healthy weight and to regain energy. It also allows mom to adjust to the stress and new demands of parenting. We also know that there's really great benefits for baby. It allows the baby, increases the chance for baby to be born at the right time and at a healthy weight. It increases the bonding time between mom and baby. And if mom is choosing to breastfeed, it gives her more of an opportunity to do that for a longer period of time. We also know that children are better prepared to begin kindergarten and perform better in school if there's the optimal interval pregnancy is at least 18 months. We also know that there's great benefits for the family. Parents and other family members have a chance to bond with the new baby. Older children have an opportunity to adjust to having a new baby in the house. It allows the parents or partners to spend more time with each other, to have date nights, which is really important to maintaining a healthy relationship. We know that overall it increases the opportunity to have more family time and to decrease the financial stress that having a new baby may have on a family. We also wanted to identify when these conversations should begin and when they should be continuing. So we identified 4 key opportunities to begin having the conversation and then to continue having the conversation. The first one being at the first prenatal visit. While we know mom's probably not thinking about when or if she desires to have a future pregnancy, we think this is a really great opportunity to get her thinking about what she wants after she delivers this baby. Again, at the 3rd trimester, when mom is being seen on a more regular basis with her provider, continuing to have that conversation. And then at the time of hospital discharge, getting her ready for her postpartum visit, and so that she can have that conversation at her postpartum visit. And so the 4th key opportunity would be, again, at the postpartum visit to have the conversation of future desires of pregnancy. And so that kind of brought us to the postpartum visit. And what we were finding is that there's a large percentage of women who are not attending their postpartum visit. And so we wanted to take an opportunity to really improve upon this and encourage women to attend their postpartum visit. And so we wanted to make that part of this campaign. And so some of the goals for the postpartum visit would really be to reframe this visit as the beginning of the next stage of a woman's life instead of seeing it as the end of a healthcare event. We want to increase the number of women who are attending their postpartum visit. We would also like to shorten the time interval from time of discharge until postpartum visit by scheduling that visit within the first 3 weeks of postpartum. And this is a new ACOG recommendation that came out in May of 2018 that talks about really making it a priority to schedule that visit within the first 3 weeks, and that, we know that women are being seen for intensive care during pregnancy and birth with weekly visits in the final weeks of pregnancy. And then it's interesting that we stop having those visits on a regular basis and we limit it to only 1 visit. And so the new ACOG recommendation is really taking a look at scheduling that first visit within the first 3 weeks and then tailoring additional visits to the individual needs of that woman, and then following that up with a more comprehensive assessment done within 12 weeks postpartum. And really what should be covered during that comprehensive postpartum visit, it should include a full assessment, so physical assessment, emotional assessment, social assessment, asking questions around infant care, infant feeding, sexuality, contraception, talking to the woman about birth spacing, her sleep. Is she experiencing extreme fatigue? Is she managing her chronic condition if one had been identified? How is she recovering physically? And then taking a look at some ongoing coordination of care if that woman needs it for future and further follow-up. We also know that one of the goals of the postpartum visit is this is an opportunity to identify or address any health concerns. The postpartum visit should be structured to provide comprehensive preventative care individualized to the specific needs of that woman. And so this is an opportunity to use this as the first preventative visit of the rest of the woman's life. And again, not seeing it as the end of a stage of care. And there should be a shift in focus from prenatal care to preventative care. This is a great opportunity to discuss desires about future pregnancies, if desired, talking to the woman about waiting at least 18 months before she gets pregnant again. It's a great opportunity to promote interconception health, emotional wellness, substance and tobacco use, chronic conditions, and healthy weight. And then ultimately reminding the patient that this is her time to take care of herself, and it's a time to consider her own health and reproductive goals. We do recognize that there are some challenges with the postpartum visit. There is no financial incentive for the provider. It's all bundled into that global fee. We recognize that there's not always a mutual priority. If a woman has had a healthy pregnancy and a healthy delivery, she may not see the need to return or to attend the postpartum visit. We know that there are actually challenges in getting women to the visit due to competing priorities. And I think that we need to really start taking a look at the social determinants of health. In a recent survey, 85% of providers felt that a patient's social needs were just as important as their medical needs, yet 80% of providers felt they were not confident in addressing these issues. And I think if we're able to understand the social determinants of health, that this may help us to better understand why patients make the healthcare decisions they make, and this may help us to communicate more effectively to increase our health outcomes. We also know that one of the challenges is that there's a disconnect between what the providers believe they are giving during that visit and what the patient actually perceives as being done. We also know that there is a finite amount of time for each appointment, so trying to address all of the needs and wants of the woman can be challenging in the short amount of time that's being offered during that visit. I spoke to the competing priorities for women. So she may have, transportation may be an issue. She is adjusting to a new schedule. Maybe she's had to return to work. She certainly has had a change in her lifestyle. There could be childcare issues or school issues if she has more than one child. And again, not always knowing what the purpose or value is of this visit. And another challenge could be an inconvenient time. The standard used to be having a postpartum visit within 2 to 6 weeks postpartum, and so that could potentially put the woman back at work. So hopefully now with the new ACOG recommendation of scheduling that visit within the first 3 weeks, that may help with one of these challenges. We also know that there are possible solutions to these challenges. I think it's important to work smarter, not harder, knowing your population ahead of time, knowing your numbers of women who are receiving prenatal care versus those that are actually showing up for their postpartum visit. Would it be possible to schedule a postpartum visit prior to discharge? So at the time that they're in the hospital, is there an opportunity for that woman to actually schedule her postpartum visit prior to being discharged from the hospital? Are we able to send a follow-up reminder via text or a phone call 1 week prior to her appointment to help this? Are we able to provide outreach to women who fail to make an appointment or miss their appointment? Can we follow up with a text message? Can we follow up with a phone call asking why she wasn't able to come and help her to make arrangements to make the next appointment? Are we connecting her to home visiting services prenatally? And then I think we really do a great job of emphasizing the importance of our prenatal visits, but are we doing the same justice to marketing our postpartum visit, which means that we really should be enlisting our community partners to reinforce the importance of the postpartum visit. So reaching out to our home visitors, reaching out to our WIC providers, our childbirth educators, and encouraging them to have these conversations about the importance of the postpartum visit. So who did we want to reach? Well, clearly we wanted to reach all women of childbearing age, and who in our community did we want to ask to help us with this task? So first we were able to reach out to our Healthy Women, Healthy Baby sites to get them on board with educating women about optimal interpregnancy interval. Then we were able to reach out to our OB providers in the community, our birthing hospitals, our home visiting agencies, and then taking a more non-traditional approach to reaching out to our substance use community partners. And then kind of in a category all by itself is other community groups. And I think at this point it's really important to reach out to those community groups based upon where our data is telling us to go. So really taking a closer look at those zip codes or those areas throughout our state of Delaware where we are seeing higher numbers of women having babies born at a interpregnancy interval less than 18 months. And how did we plan on doing this? So going out to the different sites and educating them on the resources that are available, the education on the interpregnancy interval, the campaign materials that are available, then asking them for their feedback. What did they like about the campaign? What did they like about the materials that were available to them? What were the barriers, the challenges? And then we were able to come up with a survey that asked some of those very questions. How are you using the materials? Are you using them the way that we spoke about? Are you ordering the materials online? Are you downloading materials? How many women are you seeing that come back for the postpartum visit, so that we could gain access to lessons learned by doing the follow-up survey, and then looking at a long-term survey down the road where maybe we can ask a question on the PRAM survey to gain knowledge about a woman who has had this education. Is she then choosing to wait at least 18 months before she gets pregnant again? And we recognize that, we have to use materials that are available to us. So we didn't want to recreate the wheel, and we wanted to use materials that we already had access to. And so when I first started reaching out to the Healthy Women, Healthy Baby sites, they were already using the reproductive life planning tool that's been available through the state and on DE Thrives. And how they were using this tool was at the first prenatal visit. They said that this visit is specific to all of the woman's needs and wants, and this is a great opportunity to use the reproductive life planning toolkit at this particular visit. And making sure that we are asking the pregnancy intention question. Do you want to become pregnant in the next year? And through the survey results, we were able to identify various forms of this question, including, are you planning on becoming pregnant in the next year? What are your thoughts on future pregnancies, and how soon would you like to become pregnant? Do you want to have another baby right after this baby? And again, just different ways to ask the question and to begin to have the conversation around this. And again, just whether or not that woman wants to, yes, what does that look like for her? No, she doesn't want to become pregnant again. What does that look like for her? And then letting her know that, roughly close to 60% of our pregnancies are unplanned in the state of Delaware. And asking her, does she know how long she should wait before getting pregnant again? And then making sure that we're sharing with her that after having a baby, it's a good idea to wait at least 18 months before getting pregnant, again, to be in the best emotional and physical health for you and your children. And then, of course, talking to her about the most effective forms of birth control. According to the National LTM-3 survey, only 57% of women who attended a postpartum visit reported getting enough information about birth control methods. And so it's, again, beginning to have these conversations with the woman. So how do we start having the conversations about birth control? We could start by saying, what is important to you about a birth control method? Have you tried a birth control method in the past? What are you hoping to get out of your birth control method? These are all questions that we could ask to help further their conversation. And then letting her know what the most effective methods are, including the opportunity to have immediate postpartum placement in Delaware. And at the end of the webinar, there is a resource link that can help provide more information on the Delaware CAN project and accessing free contraception. And I think it's the most important thing to get out of the conversation with her is that it's her choice, and whatever she chooses, it will be based on her values, her views, her opinions, and helping her recognize that there's a method out there that's right for her, whether or not she chooses the most effective one or she chooses to do nothing. It's our role to support her in whatever decision she makes for herself. And whether the woman ever becomes pregnant again, it's really our priority, or should be our priority, to make sure that we're addressing her known risks for morbidities and mortality. And at one of the cooperative meetings we impromptu asked the providers at the cooperative meeting, what health concerns are you most commonly identifying or addressing in your practice? And this is where we came up with the 4 pillars of health. The providers in the room identified emotional wellness, alcohol, tobacco, and substance use, chronic conditions, and healthy weight as the most commonly areas that they were addressing in their practices. And so just to touch briefly on emotional wellness, making sure that we are doing the postpartum depression screening. And if we identify a woman who is in need of a referral, that we are making that appropriate referral. Asking her about her stress levels and the demands of parenting. And then asking her about her support system. Does she feel connected to someone? Does she have someone that she can seek out for help? Another area that we identified was substance use, tobacco, alcohol, and making sure that we're asking these questions in a non-judgmental, open-ended way. You can start asking the patient, is it okay if I ask you some questions about drugs and alcohol today? Making sure that we're screening all women using an evidence-based screening tool. And I think making sure that we're asking about marijuana separately, because what we've learned is that not everybody sees this as an illicit drug. So when you're asking these questions, making sure that you're asking that as a separate question. And I think it's really important to make sure that we're being very client-centered and that we are assessing whether or not the client is ready for change. So if we identify a woman who's in need of services, asking where she is and her readiness to make some change, identifying why she wants to make a change, and then the steps that she needs to take. And then really offering compliments and encouragement, for a woman who has made some changes. For example, if you started out with a woman who was smoking 20 cigarettes a day and is down to 5 cigarettes a day, well, that's a tremendous goal that she's reached and should be rewarded, and she should feel accomplished for having been able to cut back on her cigarette smoking, and making sure that we're complimenting her so that she further wants to continue on the right path. We need to make sure that we're educating women on the dangers of alcohol, substance, and tobacco use, and then utilizing the helpisherede.com website to find resources that are available to a woman should we identify that she's in need of these services. As far as chronic conditions, making sure that we're providing a risk assessment, that we're educating women on short and long-term health outcomes, again, reminding her that her chronic condition can affect her pregnancy, but also that a future pregnancy may have an effect on her chronic condition. Making sure that we're making the appropriate referrals and that we're discussing medication management with her. And remembering that, if we see a woman who is not compliant with her treatment, we need to consider the social determinants of health. Could it be that she has unstable housing, or maybe she doesn't have access to supplies, or maybe it's a transportation issue as to why she's not compliant with her chronic condition. So really making sure that we are following up as to the reasons why. And then making sure that we're having discussions around healthy weight. We know that the majority of postpartum women desire strategies for weight loss, and it's often the providers who don't necessarily know how to address this topic. So making sure that we're leaving the door open for future discussions, that we're encouraging the woman to set realistic goals, encouraging her to increase her exercise or to just get moving. And I think sometimes we focus primarily on numbers, so we focus on the BMI, and for most people, they don't really understand what that number means. And so let's kind of get away from that number and encourage her to just make some lifestyle changes. And then if I can take anything away from the postpartum visit, is making sure that we're asking her, what can I do for you? Because this is her time. She may have her own questions, her own concerns. She may have her own agenda. And as providers, we may have our own agenda that we may need to get away from in order to address her concerns. And we need to be respectful and mindful of her time. And in the end, we want to make sure that we're keeping the lines of communication open for future discussions. We want her to buy into her own health. And we want to ask what is a priority that she would like to address. When we started to consider this as an initiative, I spoke earlier about how when we looked at the fetal infant mortality review cases, we were seeing little to no documentation of the education being provided. And so we can only assume that the education was not being done. And as a nurse, I can remember from very early on in my clinical stages that the one thing to remember was document, 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 because if you didn't document it, then it didn't happen. And so making sure that when we are having these conversations at the first prenatal visit, at the third trimester, and at the postpartum visit, that we are documenting that we're having these conversations, and also documenting reproductive life planning, pregnancy intention, and the birth spacing. How are you documenting this? Are you documenting it each time that you have this conversation? And we know that this is really important because data collection is how we promote practice change. So what resources do you have available to you and how do you access them? So I talked about the reproductive life plan that's available on DE Thrives. It's both in English and Spanish, and we are asking that this be used at the first prenatal visit just based on feedback that we gained from our Healthy Women, Healthy Baby sites. The Give Them Some Space brochure would be a great time to use. This would be at the third trimester visit when you are seeing that woman on a more regular basis and towards the end on a weekly basis. The Why Wait at least 18 months to be utilized at the hospital, time of hospital discharge, and simply because it's pictures, it's easy for someone to pick up. We all know how bogged down a woman can feel and overwhelmed she can feel as she's being discharged from the hospital. So it's a really quick tool for her to pick up and go over when she has the time to do so, and it'd be easy for hospital staff to go over this really quick tool with her. And then the benefits checklist could be utilized at the postpartum visit, explaining benefits for mom, baby, and family in a checklist form, so you can simply check off the key points that you've addressed with the woman. When you order materials online, the Give Them Some Space brochure, you'll actually get the implementation letter, which really gives you clear directions on how you can implement this in your own practice. It encourages you to have a champion in your office who really can push this and promote this. And then the provider letter that's been signed by Dr. Rattay, Dr. Paul, and Dr. Cole-Morgan, just really advocating for the birth spacing education and increasing the number of women who are being seen for a postpartum visit within 3 weeks. And so how do you order these materials? You can go to dethrives.com and order the materials. Click on the reproductive life plan to order or select the option to download them. You can also scroll down to the birth spacing brochure, add them to the cart, and then check out. And if that's something that you are not able to do, then you are able to contact and email Joelle and Kimmy directly, and she'll be happy to help with the ordering of those materials. And our resource page, again, checking out DE Thrives for more information on materials and what's happening throughout the state of Delaware. Other initiatives are listed on that website. And then our Delaware CAN, as I mentioned earlier, that can offer information on contraception and immediate postpartum placement. And then a whole slew of other resources on preconception health, our COIN initiative, what we're doing in the state of Delaware, accessing before and beyond. There are provider toolkits and reports that are available to help with the education of preconception and interconception care. And Show Your Love campaign as well is a great resource to access. And then the fourth trimester project that pretty much talks about the new ACOG recommendation of recognizing that a woman should be seen, have a more comprehensive health assessment, physical, emotional, social, within the first 12 weeks postpartum. And then as a follow-up, as I said, we created a survey to identify lessons learned through the initial campaign efforts. There is a provider survey link online, so after you've watched the webinar and you have initiated this in your own setting, you are able to take the survey online and let us know what you thought of the campaign. Any suggestions or feedback is completely welcomed. And then if you have any questions, please go ahead and contact Joellen Kimmy, and her contact information is found below. Thank you very much.
Thank you. Thank you, Heather, for a very informative and insightful presentation. And thank you to each of our audience members for participating with us today. Please take a moment to complete the survey using the link on the follow-up slide. If you have any questions, as Heather mentioned, about the information or resources presented in this webinar, please reach out via the contact information provided within the last slide of this presentation. Thank you again.